Good morning, everybody. It is morning for me. I don't think it's going to be morning for you. My name is Ruben Martinez. I'm an assistant professor of psychiatry and human behavior and the training director of our implementation science program here at Brown University called the Bridge Program, which is Brown research on implementation and dissemination to guide evidence use. Our goal is to help build capacity for implementation science in the university and the state. And today I'm going to be talking to you about applying implementation science to your clinic and continuous quality improvement or quality improvement projects. So, what I'm hoping that you will get out of today is to that you will be able to define implementation science and how it can be applied to healthcare settings, discuss the benefits of a system level approach to understanding implementation challenges, describe common barriers and facilitators to the implementation of evidence-based practices, and describe a four-step model for practical implementation. The goal here is that after you have watched this, you have a decent sense of the four steps that you might want to go through to apply implementation science principles into your quality improvement work. All right, so let's get started with part one. Implementation Science 101. All right, so this is the QR code. You can scan it. It's an article there for you. But there is a 17-year research to practice gap, and that 17 years, the statistic we commonly cite is that it takes about 17 years for 14% of research to make its way into routine care. This is something that you all have seen over the course of your careers, I'm sure, practices, procedures, policies, you name it, that haven't made their way into routine care, even though they are evidence-based. We know they work and we know they're better than some existing alternative. What that means is that most people have limited access to evidence-based treatments. This has some really clear implications for health equity, for health disparities, and just generally for high quality medical care. And it's worth noting that this gap just doesn't just exist in medicine or in psychiatry or psychology. It also exists in education and essentially every other sector where there is a robust research base. It's a pervasive gap, and implementation science started really in the social work medicine realm, but has really rapidly expanded to other settings and to other areas. So, what is implementation science? What do we do? So, one of the primary things we do in implementation science is that we evaluate what we call determinants or barriers and facilitators to using evidence-based practices. So this really involves understanding in a given context what are the barriers, the things that are going to get in the way, and what are the facilitators, what are the things that are going to help implementation. We also develop and deploy methods to improve the use of evidence-based practices in routine care. These are called implementation strategies. And I'll talk a little bit more about these. But implementation strategies, I don't want you to be scared of them. They're really just things like training, providing evidence, redesigning workflows, those kinds of things. But what is important about implementation science is that we don't just deploy these willy-nilly. We don't just do the strategy that sounds best. We really try and take a measured, sequential, strategic approach to developing, deploying, and testing the impact of these strategies, which is the final point here, that we want to understand whether we have made an impact on implementation outcomes through these implementation strategies. So the idea being that we want to essentially develop interventions for organizations, interventions for units, interventions for hospitals that will help to increase the adoption, implementation, and sustained use of evidence-based practices. And I do want to say here that I say evidence-based practices, and I'm generally pretty lenient about what I mean by evidence-based practice. I don't want to, there's a epistemological or like philosophical conversation about what constitutes evidence. And I think different evidence uh, different evidence is important for different problems at different speeds. So that's a conversation you all can have amongst yourselves. But there are lots of thought papers and discussions about what truly constitutes an evidence-based practice, and that's not something that I'm going to go into today. All right, so you might be asking yourself at this point, how is implementation science different than what I'm already doing? A lot of people, we hear this a lot as, well, I'm already implementing something in a clinical trial. That is not what we consider implementation. You are implementing a clinical trial, but, and I'm not saying that you all are clinical trialists, but this is how clinical trialists tend to think. Implementing a clinical trial is not the same thing as implementing an intervention into a complex healthcare system because of the following reasoning. So let's take a moment to think about first what exactly we're testing here. So first thing is all of our implementation and intervention science revolves around a thing, many things, some things. And these things are interventions, innovations, practices, pills, procedures, policies, anything that's new or that is um, impactful that we want to put into a setting, right? And so this could be something like cognitive behavioral therapy. It could be a new type of medication for managing blood sugar. It could be a new procedure. It could be an AI stethoscope. Like they're just any kind of things can be your thing. And I'm going to, in a second, give you an opportunity to just think about what your thing is. And your thing might be educational in nature, right? It might be a new way of, um, let's say, like a new way of training trainees. It might be a medical procedure. It might be even something, I mean, I like to think about this in my personal life. Like sometimes my thing that I'm implementing is something like a new workout routine, right? So your thing, you just want to define it, but your thing can be any number of things. All right, so we're going to refer to this as the thing. And this is actually a published paper that was a teaching tool that Jeff Curran used for a long time. And people encourage him to just put it out there. And I think it's just really nice, simple language. So, all right, so we have our thing. In medical research, we have efficacy and effectiveness research, which really looks at does the thing work for whatever it's intended to work for. So efficacy research refers to really tightly controlled trials. So you're controlling as much of the as much of the conditions around testing of the thing as you can. So you're really maximizing that internal validity as much as you can. And typically efficacy research happens really early on because we want to know if we control for lots of things, does this thing work? Because if it doesn't work when we've controlled for a lot of things, then what are the chances it's going to work when we control fewer things? After we've established efficacy, typically we move into effectiveness. So then the question becomes, the question becomes, does the thing still work when we control fewer elements of our study design? So that might be that we are not using super well-trained interventionists. It might be that we're giving people fewer outcome measures and we're really focusing our outcome measures. There are all kinds of ways that we can take down the control and move into effectiveness research. But both questions are asking the same thing. So if you have a treatment for depression, does depression get better? If you have a treatment for blood sugar, is blood sugar more well managed, etc. So that's that kind of typical clinical trial. The implementation research focuses on how do we help people or places do the thing in the best way possible. And so it's a big frame shift because what we're actually thinking about are different kinds of outcomes. We're not thinking about an implementation research. Does the thing work for depression? We're asking, can we help clinicians, practitioners, nurses, etc.? Can we help them use the thing better, use the thing more, um, deploy it with more quality or consistency? And again, those implementation strategies are the methods or techniques to help people or places do the thing. Implementation outcomes, on the other hand, are methods or tools that measure the success of implementation. So again, we're thinking this is just demonstrating this frame shift a little bit that clinical trials where we evaluate the efficacy or effectiveness are not, they don't have the same goal as implementation studies. We can combine them. So for anyone who is interested in more of the scientific design of how we do this, we often have trials where we combine clinical outcomes and implementation outcomes into one trial. They're called hybrid implementation effectiveness studies. Okay, moving on to our overarching implementation process. So this is the process we're going to be discussing today. So this is not exactly published, but this is derived from many published materials. So this is a framework that we've used in Advance RICTR in pilot work with real clinics, and it works very, very well. This is a model that I use pretty frequently in my own work, especially when it comes to quality improvement. What you'll find is that the implementation literature, while very robust, is also very hard to navigate. And so it can be really helpful to have someone who can interpret or translate that for you, so you can start to understand some of the language that cuts across all the literature. And implementation, I'll just make a quick note here. It started formally as a field in 2006, even though its roots go all the way back to things like agriculture and those first clinical trials. But really, the language of implementation started in 2006, so it's only been about 20 years. But it is the literature has exploded in the last 10 years. So you'll find that if you look, you will find very little before the year even 2010. There's not a whole lot out there. And then 2020 to 2026 has been a massive explosion in implementation literature. Okay, so back to our uh, back to our program here. I'm sorry for that detour. So here are the steps that we're going to go through. We're going to explore, really understand the context. I think this is a really critical part of setting up the rest of your implementation effort. And you understand your context, but I would argue that depending on your role, you may understand your context differently than people in other roles around you. So once we understand the the ecosystem of barriers and facilitators, or these contextual factors that are important in implementation, we then want to prioritize them, because what ends up happening is we get this menu of a lot of different things, but we're not really sure how to make decisions based off that. So prioritization helps us make those decisions. We then want to plan for implementation strategies, which is really developing those strategies, and then evaluate. And we might go back to the drawing board a couple times, and the arrow only goes back to plan. You may go back to exploring. Something that happens often in implementation efforts is that you have this problem that you want to solve, and then all of a sudden, some technological advance comes around, or your organization starts a new initiative that totally negates that problem or changes the problem. So you may have to go back to that explore phase. All right. So let's go through these in some detail. So in the explore phase, what we're really trying to do, we might call this pre-implementation. What we're really trying to do is to understand first, who do I need to hear from before I implement? This is a really important under underused approach, is that we really want to understand who our end users are. And the reason why is because if we develop strategies based on barriers that we think are true, we are very likely to miss some things, and we don't want to miss things in this process. So once we identify who do I need to hear from, we also want to then understand what are their perspectives on the barriers to implementing this new practice in this setting. And the end result of this process is that we want a list of implementation barriers and facilitators. I usually gather information on facilitators, but I don't use it quite as often in my development of strategies. I focus a lot on barriers. It's a stylistic choice, but what we want are these contextual factors that influence the success of our implementation, or that we think will influence the success of our implementation. Just take a few minutes to generate the end users that are going to be impacted by the implementation of your thing. This could include, but isn't limited to, the following groups: patients, family members, healthcare staff, front desk staff, learners, trainees, custodians. There are a lot of people who may be impacted by your implementation effort. And I encourage you to take a broad lens at first before you start to whittle down. So take a couple minutes to write down those end users. I'll give you a moment to pause here. All right, so now we're going to talk about what are barriers or determinants and why are they important? So determinant is any factor that affects implementation, a factor that determines the success or failure of our implementation. Oftentimes what we're thinking about are perceived determinants early on, like what do you think is going to what do you think is going to influence implementation? But oftentimes we also look at actual barriers too. So things that really got in the way looking backwards as we look backwards. So a barrier is anything that makes implementation or use of your thing harder. Oftentimes, we want to develop strategies that overcome those barriers. A facilitator is something that makes implementation or use easier. We want to develop strategies that leverage facilitators. Something that's really important to think about with determinants is that they occur at multiple levels. And I think this is a really important point that is not usually well captured in QI methods. And this is an ecological model. It's based off of many ecological models before it, but some of the, kind of like the early ones were Urie Bronfenbrenner's ecological model of human development. But really, this is the idea that determinants live in different levels of our setting, right? And so at the innovation level, sometimes our innovation, our thing is too complicated. There isn't really a good reason to use it over another thing. Sometimes barriers exist at the individual level. Sometimes they're attitudinal. Sometimes it's self-efficacy. Sometimes there are things about knowledge, willingness to use. Those are all things that exist at individual level. Sometimes barriers exist at the inner setting level. Sometimes it has to do with the space of your practice, where your practice, the kind of um, configuration your practice has physically. Sometimes it has to do more with practice policies and procedures. And determinants also exist at the outer setting level. So things that are generally outside of your sphere of influence, like other community organizations, state or federal policies, etc. So barriers can exist at all these different levels. And generally, why I think it's important to think about this kind of nesting, right? Because that nesting is innovation within individual, or sorry, individual within inner setting within outer setting, and the innovation is sort of nested in all of that. The reason why is because if we can understand where the majority of our barriers are, that's generally a good level to at which to develop your strategies, which we'll talk about in just a sec. The other uh, thing I want to note here is that, oh, it is escaping me what I was going to say. Oftentimes what happens in implementation efforts early is that people get really caught up in things they can't control. And there are certainly going to be things you can't control. And what this also helps us do is identify what we can control and what we can't control, which is part of how we're going to move forward with our prioritization. But if you have all of these barriers at the outer setting, it becomes really hard because there are certain things you can't control about the outer setting. You can't control how other organizations do their work. You can't control federal policy. You can advocate, of course, but there's nothing you personally can do to change that right now. And so what we try to focus on are what are the things within our spheres of control that we can influence right now. All right, so how do you identify these things? There are a lot of different ways to do this. And because this is a 50-minute lecture and I'm asynchronous, I'm not going to be able to go through a lot of these in a lot of detail. But what I encourage you to do is to develop a really informal interview guide for the people who you want to talk to and ask them through regularly occurring meetings. Hey, we're thinking about doing this thing. What are the things you think are going to get in the way? Right. And so this could happen in staff meetings. It could happen in informal conversations with end users. We call these like key informant discussions or interviews. It could be through more formal focus groups or individual interviews. We also have this really cool method called premortem brain writing, which is like sounds kind of absurd, but really what it's a uh, failure modes effect analysis where you sit down with a group and you say, look, this is the thing we want to implement. Imagine 5 years in the future, we've implemented this thing and it's failed. Why did it fail? And that's a really specific bit of language. You ask why it failed. And through that, you can identify all these different things that will get in the way of your implementation effort. So these things, some of them are actually like we have worked with clinics to develop interview guides that are really very informal. And this process can be done in a, like I said, in a much more formal way, but it can also be done pretty robustly in an informal way or in a way where you're not doing like a research project. Because again, we're thinking about quality improvement. All right, so now you are going to spend some time thinking about how you're going to match your end users up with your identification methods. And so you don't have to have a method for all your users, but I would encourage you to have as many as you can for all the users you identified. So take some time to think about with patients, we will do X, with family members, we will do Y, with healthcare staff, we will do Z. Okay, so I'll give you just a couple minutes to pause on that. All right, so just some general tips for this explore phase. So be very specific about your plan for documenting. Having these interviews is great. Talking to people is great. Make sure that it's documented, it's recorded, and that you have some sort of way to isolate those barriers. And so that might just be through group conversation and consensus where you say, okay, it sounds like the biggest barriers are X, Y, Z, right? And you're likely to come up with anywhere between 6 and 20 or more barriers. The more informal it is, the fewer barriers you will come up with. Um, be really mindful about who the best person to ask about a barrier is. It's often the case when I work with people who are in more leadership positions, they are very quick to assume the source or cause of a barrier. And our perception in different roles of what a barrier is for other people is not going to be necessarily what those people tell us the barrier is. And this gets to this next point, which is the barrier really needs to be specific. So I see one of the biggest areas I see people flounder in this area is that the barrier is, well, I don't have time for that. So if someone tells me I don't have time for that, there are a million things that I can interpret from that. Time can mean time. It actually could mean I don't have the time. It could mean I don't have the time in the session because of other competing demands. It could mean I don't have time because of other competing demands outside of my session. It could mean it's not a priority to me. It could mean I don't want to do it. Time is this weird catch-all that doesn't really mean anything until you dig into it. So you really want to think about what does time mean, and is time actually representing the barrier that you think it's representing? This is a huge, very, very important piece is to be as specific as you can with your barriers, because if you're not specific, you'll have a very hard time developing a targeted strategy to overcome it. Um, the other thing is I encourage you because many of you, I think, are in practice settings. You may not need to talk to everyone. So you might prioritize like who are the top 3 most important groups that I need to talk to, or the top 2 most important groups I need to talk to who are really going to experience this implementation effort. Think about managing your resources and making a feasible process for yourself. And as much as you can, I really encourage you to use regularly occurring meetings for this, taking some time, even 20, 30 minutes out of a meeting to have a discussion so as to not add burden. One of the things, adding burden of implementation onto somebody's job can sometimes be it can be a challenge. It's not always a good thing and typically isn't a good thing. All right. Now we're going to move on to you have this list of barriers, right? So you have this list of things that are going to get in the way or these facilitators, things that are going to help. What do you do with those things? This is where we think about decision making. So now we have a list. We want to move our list into a set of seeds for decision making. I like that. I just made that up. All right. So what we need to do then is prioritize those barriers and facilitators. So we want to understand what are the most salient barriers and facilitators. What are the ones that we think are going to make the biggest impact, and what are those that are in our control, within our sphere of control? Because we don't want to get caught up only thinking about the things outside of our control. So we need to understand a couple things. First, who needs to be at the table for this, right? Who really needs to be there to prioritize these barriers? That group, what often we do is we develop some kind of implementation team, or we might just use those regularly occurring meetings again. The next question you want to ask yourself is, how am I going to evaluate how are we going to prioritize barriers? Is it going to be um, quantitative or qualitative? And I'll show you an example of each one. Actually, I may only have qualitative here because it's the easiest thing to do. So we'll come back to that. Okay, so just a quick introduction. We identify more barriers than we can hope to address, and sometimes they're out of our control. We have to have a way to prioritize what we go after as we develop our implementation strategies. And we can do this in a quantitative way or a qualitative way. This is a QR code to a free resource by the Impact Center, which I was a core faculty member in while it was still operating. This is a really good primer on the quantitative method. And I'm not going to talk a lot about the quantitative method because it's just a little bit more detailed than we can go into with the time that we have. So what's important to know here is that you can prioritize determinants on a number of different criteria. It might be that you prioritize on importance. So how important is this barrier likely to be in the success of our implementation? And you might also prioritize on frequency. How frequently do we think this barrier will occur? There are also other ways that you can, or other criteria you can use. Things like, what is our existing motivation or our organizational motivation to work on to address this barrier. This is often, we work with schools in the state of Rhode Island. One of the most important ways we prioritize is this aligned with the district's overall mission or value to address this barrier? And so an example of this is an example we use of determinants to starting a garden. And so we have things like limited outdoor space, lack of time, cold weather, lack of tools, inadequate knowledge about gardening, and not having a hose. And so what we actually will do, you can do this on a whiteboard, you can do this on a Miro, like an online diagramming software, Lucidchart, Lucidspark. Google has one called draw.io, I think, that's free if you have a Google account. You can use any number of those things. And what you actually can do as a group is you prioritize them to figure out what is in our go zone. So the go zone is here. These are high feasibility, high importance determinants. Yeah, that's right. And so we want to really, as a group, come to consensus on what is in our go zone here, what is in our no zone, like what are we just like, it's not feasible and it's not important. And so the idea is that you take your determinants, you prioritize them using some sort of 2 by 2 grid here with two of the criteria mentioned. You can also add a third dimension to this by, like, if all your sticky notes are yellow, if you want to say, we want to pick ones that are high on a third criterion, like, for example, let's say equity impact, you could turn that sticky note a different color. And that would indicate that it's sort of like high on the third dimension because we're not visualizing this in 3 dimensions. We're visualizing it in two. I know it's like a little funky, but okay. So some tips for that prioritizing phase is that I really encourage you to do whatever's going to get done, like whatever feels like it's going to be the most feasible approach. Oftentimes we focus on importance and addressability. Some people like modifiability. There's no like gold standard criterion. What's important is that you define your criterion. So what does importance mean? What does addressability mean? It's it's not important that you pick one word over the other. What's important is that word is meaningful and well defined. Um, One thing to note is that prioritization can sometimes be tricky relationally. And so if you do work in a setting with low psychological safety, sometimes prioritization in this way might be best done with separate teams. Um, and it often illuminates power dynamics and reveals challenging barrier-related discussions. But on the other hand, it also helps really bring up this extremely helpful crosstalk across teams. And so when I've done this in clinics, what we found is that the people in records and registration talking to the front desk are hearing new things that they never heard before. The clinical team was hearing new things from records and registration that they never heard before, and vice versa. So an exercise in building a shared understanding as well, and to share some of the things that were getting in the way that were previously unspoken. So it can be a really powerful tool to use relationally and something that you should be cautious about, or I would say planful of, depending on the psychological safety of your clinic. And then importantly, um, as I said, you can do this with sticky notes on a whiteboard. Just make sure you take a picture. Again, this idea of documenting, you don't want to leave and then say, oh no, we didn't record what we actually decided on. We didn't take pictures of it. And I think that sounds really silly and simple, but I have seen it happen. And finally, it's important to end this phase with a consensus discussion of priority barriers. So then what are our high priority barriers? That top right quadrant is meant to be a consensus, right? And so we really want to get to a cohesive understanding of what our high priority barriers are. All right, we're going to move on to our planning phase. So our primary goal is to have one or more strategies that are linked to those high priority barriers. And you might have one strategy for multiple barriers. That's totally possible. You might also have multiple strategies. So what we want to understand is what are the highest impact feasible strategies to overcoming prioritized barriers? And again, who needs to be at the table when those strategies are developed? Okay, so a what are implementation strategies? We talked about this a little bit. There's a resource online called ERIC, Expert Recommendations for Implementing Change. That's a really nice starting menu of implementation strategies. And this menu is like a Cheesecake Factory menu. Like there's way too many on there. They're not very well defined, which actually is unlike the Cheesecake Factory menu. I think that has a little bit more definition, but it's just a starting point for you to think about what are the ways I could make change. Tom Waltz did a kind of a synthesis of Eric's strategies and put them into buckets. And so it came out with these buckets, providing interactive assistance, developing stakeholder interrelationships, supporting clinicians, utilizing financial strategies, etc. So you have lots of different ways lots of different strategies you can use, and that's a really great resource. And it's free, it's open access. You can find like lists of Eric strategies online for free. They're everywhere. What is important is that we are matching our strategies to our barriers. So oftentimes what we see in really rapid improvement efforts is that the strategies are not well matched to the barriers, and there isn't really a good hypothesized connection for why that barrier would be overcome with that strategy. So, as an example of this, if your determinants are that you have a lack of knowledge, you want to do best practice interactive experiential educational sessions, right? That's a really nicely matched barrier. If you have a perception reality mismatch, meaning that everyone in your clinic or people in your clinic believe that they're doing something way more than they're doing it or way less than they're doing it, you might try and do something like audit and feedback, which is a really well-known quality improvement process where you actually audit what is happening and you feed it back to teams. I have a really good article about best practices for audit and feedback, but it is a pretty robust and useful implementation strategy. Um, for beliefs and attitudes, you might um, engage peer influence or opinion leaders who can really help to change those attitudes or beliefs, right? So we want to just make sure that they're targeted. What we don't want is to develop a strategy that is what we think matters. And so I've seen this a lot where clinicians will say something like, well, we just don't have the time to do this. And they can explain more about that. And what administration will do is that they'll say, okay, so you guys don't have the time to do it. We're going to send you an email to tell you how important it is that you do it. And that is not a well-designed implementation strategy because it's not actually getting at the core of whatever that challenge is, right? Like telling clinicians that something is important is not going to help solve whatever that time-related barrier is. Okay. So, what does it mean to develop a compelling strategy? So, first, what I would encourage you to do is to brainstorm some solutions. So, this is our barrier, right? Our barrier is that our patients don't know about the thing, or our clinicians don't know about the thing. Brainstorm some solutions. You don't need to use the ERIC language. Again, that's just like a menu, but really brainstorm some solutions. Write out those strategies. So something like sending a nudge or text message reminder, developing a newsletter, providing additional training, and then gut check how compelling that strategy is. And this is something that I do a lot more formally through something called causal pathway diagrams, but something you can do just by asking your team, how or why will this strategy overcome the barrier? And what you're really trying to get at is, do we have a really good theory of change, but we're doing it in a really informal way? Because what we want to have, we want is to feel compelled that if we do this strategy, it is going to activate something, deactivate something, change something that's going to overcome our barrier. And if we can't verbalize what might seem like a very obvious connection there, then it's not probably not worth doing that strategy. So as an example, if we did have something like um, an attitudinal barrier, right? And one of the suggestions is, well, what I think we should do is have a group meeting about this, and at as supervisors, we should tell them how much we want them to do it. You would ask, how or why is that going to overcome that barrier? And having a group discussion can really illuminate if we have a clear theory of change for how this thing will work, right? How will this strategy work to overcome the barrier? I'm not giving very specifics because I don't have a ton of time, but this is something I think is very, very important. And then you can actually prioritize the strategies you developed in the same way you prioritize the barriers, right? So all of this in total here, we're talking about something like 3 to 4 hours worth of work. That's including the analysis, including the meetings, etc. So we're not talking about a ton of time. It's just a matter of getting people together and then really trying to work through this sequentially. Then, once you have this candidate group of strategies, right? You have your strategies now of like, these are the things that we are going to do. We're going to have more training. We're going to have person X is going to act as our opinion leader, right? And they're going to like talk to their peers. We're going to add a nudge. Then you want to specify those strategies very, very clearly, which is the who, what, where, when, why, and how of your strategies. And so you want to document who's going to do this, when's it going to happen, where is it going to happen, why are we doing this, which is really that gut check, the rationale we talked about. Um, and having that documented in an Excel spreadsheet, a Word document, however you want to do it, build that accountability and build those strategies together, right? So this is something that is co-developed with your team. This is how we are going to go about making this change. Okay, so this is just some examples of specifying strategies for that same example that we had before, which was um, uh, barriers to starting a garden. So using a picture that you already have. So in this case, our action step would be that we designate a pitcher that we'll use on a regular basis and have readily available to water your plants. And this was to address the barrier that we didn't have a hose, right? Okay, I'm not going to go through this. You can pause and rewatch this if you'd like. Um, so some tips for this phase is that it's important to focus on how compelling the logic of your strategy is. I made a really big deal out of this because I think it's very important. Um, that you can also ask people sort of on a scale of 1 to 10, we've done this before, is how compelled do you feel that this strategy is the right thing to overcome this barrier? And you can just record those or do like a show of hands, that like a rank order vote. There are all kinds of ways you can do this. It doesn't have to be, again, like some super formal research procedure. It's okay if your strategy is just one small thing. Sometimes small things can make a huge difference. And again, the same thing is the strategy prioritization. End this phase with a consensus discussion of your priority strategies. And I like to have then a discussion again about how would this fail, right? Just really asking the question. We've done this. Um, we're 3 years in the future, this thing has failed. We're 6 months in the future, even this thing has failed. Why did it fail? And really documenting and refining that plan based on that information. All right, we're hitting the home stretch here. I know I've gone through this very quickly. This is like the most high level. This talk is usually somewhere between an hour and a half to 2 hours. So I've tried to cut it down a ton for you. And I hope maybe it will just bring up more questions for you and give you some insights into how to use these things in your clinic. So now we want to go through this evaluate phase. So in terms of evaluating, we want to understand what are the most important outcomes we want to demonstrate. And these might be implementation focused outcomes or service level outcomes. And what is the level of evaluation that I need? And so the end result is that we have specific measurable outcomes of this stage. This is Enola Proctor's implementation outcome framework. This is one of the first frameworks for evaluation we had in implementation science, and it is definitely one of the most durable ones. So the implementation outcomes here, as you see on the left, is we have some outcomes that are perceptual in nature. So how acceptable is our thing? How appropriate is our thing? How feasible do people think it's going to be? But then you also have these behavioral outcomes. So what is the extent to which it's adopted early on? Are people using it with fidelity or quality? How much has this thing been institutionalized in our sort of like routine day-to-day operations? And how sustainable is this thing? The idea here of this logic model is that if you implement your thing well, you're going to have changes to your service. Your service will become, in whatever way related to your intervention or your thing, more efficient, safer, more effective, more equitable, more patient-centered, and more timely. And if those things are true, then we should see also changes in client outcomes, things like satisfaction, function, symptomatology, diagnosis, etc. So the idea here is that these are upstream outcomes that eventually will lead to downstream improvements for individual patients. This is another way to conceptualize implementation outcomes. So REAIM is reach, effectiveness, adoption, implementation, and maintenance. And so this actually this combines the implementation and clinical outcomes, but it's really asking the question of who is or was intended to benefit from this and who actually participates or is exposed to your thing. For effectiveness, that's really the clinical effectiveness question. The adoption question is the same as the Proctor framework, which is who chose to adopt it and who didn't. Implementation really refers to like fidelity. So that's how much is the thing being used, how well is it being used, and then maintenance is really that sustainment. So as you can see, there's quite a bit of overlap between the REAIM dimensions and this outcome model. You can just pick one or the other, whichever one feels like it's most right to you. And one thing to know is that you don't need to measure all of these things, right? So you might, early on in an implementation effort, you might focus on things like acceptability and appropriateness. Like, I think this thing is good and I think it's appropriate for our setting. But later on, once you've already established some baseline of, yeah, people generally like this thing and think it's the right thing to put in our setting, you really want to focus on behavioral outcomes. So how are people using the intervention? With what intensity are they using the intervention? Who are they using the intervention with, and who are they not using it with? Importantly, right? Those have huge equity implications. And you can do these things, you can evaluate these quantitatively or qualitatively. So quantitatively, you can use a survey or questionnaire, but you can also develop an individualized item. So I really like using routinely collected data or EHR data that you can pull reports from regularly, and put those into things like run charts, or in some cases they're already in a graphical format in something like a flow sheet. Right. So the more you can build it into routinely collected, the better. And those are typically our implementation outcomes, right? Because if you're wanting to know how many times is X thing done, that's something that can be built into the EHR through something like a flow sheet. You can also use things like informal qualitative methods. So things like group discussions, and then chart reviews. So EHR data capture. So looking at the actual narrative to see what was done. Oh, maybe capturing a certain percentage of cases. We have a guide for selecting implementation measures that can walk you through. It's meant for people who are more practitioners. It can walk you through how you can do more of the quantitative, like survey questionnaire kind of measure selection. So something for you to think about there. Okay, and some tips for this phase is that when we measure outcomes, it's a really great way to develop scholarship and advocate for resources. So when you're doing a QI project, I think many of you know this, you want to demonstrate that your project made a change, right? And clinical outcomes are important, and I would argue that implementation and service outcomes are also very important, especially for service level interventions. Low friction, meaningful measurement is the best thing to do. So as much as you can build this in, as much as it is not a manual data capture, the better. And knowing all those things, be as specific as you can with your outcome metrics. Don't measure just to measure. So sometimes when you first start, it can be easy to say, we're going to measure acceptability and appropriateness and adoption and this and that. It's like, just pick the one or two things that are most important for advancing, for showing that this thing worked and for advancing the resources that you need to implement this at scale or at a larger level. Um, and just like with our strategies, make sure your plan is written down and the person who's responsible for collecting and aggregating the data, whether that's data pulls, EHR data captures, make sure they know what they're doing, why, how, what frequency, etc. And make sure you monitor that data early to make sure you're getting what you need to get. Because you don't want to get to the end and realize that the data you gathered was not the data you wanted or needed. And then the last thing is, I think it's important to develop success criteria and to say, okay, so we have our data pool, we know what our outcomes are. If we're not at, X% improvement, like a benchmark for improvement in 3 months, we're going to switch up our strategy, right? So that's an important thing to do, very aligned with what you would do in quality improvement. Okay, so that is the end of this. Of just thinking a lot about I know that this was a really high level overview. We went very quickly through a lot of things. I would like to make sure you all know where to get more information. A lot of this information is stuff that we actually do personally, like with clinics. I either do this through consulting or through my work with Advance or ICTR. But you can consult with our team, the Bridge team. All of us have we all know how to do this stuff. And so our bridge team is open. If you are Brown affiliated, if you're with one of the hospitals, you can always request a consultation with Bridge. I believe there's a 2 or 3 consult limit, but it is free for the first 1 or 2. And then you can also request, if you are affiliated with Brown, the hospital's URI, or the VA, you can request a consultation with me through Advance RICTR through the Implementation Science Consult Service. I think it's called Informatics and Implementation Science for now. So you can request a consult with us. I really appreciate it. I wish I could have been there in person with you all. I really appreciated this opportunity to talk with you, and I hope that you've gotten something out of this that you can take away from it. I hope you all have a few minutes to discuss that. And otherwise, thank you so much. I really, really appreciate it. Here's a QR code to the Barrier Prioritization Toolkit, and you are welcome to email me if you would like to discuss any further. I hope you all have a great rest of your time and hopefully talk soon. Thank you.